Good morning, good afternoon, and good evening, depending upon where you are in the world joining our webinar. Today, we're going to be listening to a presentation on substance use disorders and type 2 diabetes, integration of evidence-based diabetes care to promote quality health outcomes by Professor Adejumo. I do have one disclaimer that I need to mention is that webinars and online events delivered and hosted by the International Substance Use Professionals, ISSUP, and ICUDDR are provided for informational purposes only. They are educational in nature and do not constitute medical advice, diagnosis, or treatment. So a little bit about Professor Adejumo. Dr. Oluremi Adejumo is an assistant professor at the University of Maryland School of Nursing. She's a fellow of the International Academy of Addiction Nursing and International Council of Nurses. She's a certified global nurse consultant. Her primary goal is to help strengthen the nursing capacity in the US and abroad, prioritizing prevention, particularly in Nigeria and other African nations. As a transformational leader, she has facilitated many community-based program development, even in a complex adaptive system, to promote high performance. Her expertise lies in the translation of evidence-based research into practice. To share her knowledge, she mentors other nurses to be more effective and efficient in their practice, particularly with practice delivery as they perform patient-centered care. As a proactive leader, her aim to empower nurses is evidenced in her engagement in nursing activities that foster professional growth. When Dr. Adejumo recognized the threat being posed by substance misuse in the citizens of Nigeria, within a short duration of her membership and engagement with the International Nurses Society on Addictions, INSA, she facilitated the establishment of the first chapter in Africa, INSA Nigeria, as she works collaboratively with her nursing colleagues and healthcare professionals from other disciplines. So please allow us to listen very intently to Dr. Adejumo. It's over to you.
And thank you, Kevin. I appreciate the warm introduction. Thank you so much.
Very welcome.
To the leadership of ISSUP, ICUDDR, and IntNSA, I thank you for the enormous background work you've done to make this presentation happen today in commemoration of the World Diabetes Day. So this webinar is timely, and more than 50 of those who have diabetes they are unaware that they have this disease. And this chronic disease is preventable. So this webinar is very, very timely. So the learning objectives for today, at the conclusion of this webinar, participants will be able to define diabetes mellitus and substance use disorders and associated complications. They will be able to identify the associated risk of developing type 2 diabetes mellitus in substance using populations, and illustrate the global epidemiological trends of substance use disorder and type 2 diabetes. And lastly, participants will be able to apply health promotion and disease prevention framework in culturally diverse substance using populations. As we dive in to today's presentation, or this webinar, I want us to first reflect on family members friends, and other encounters who have died of diabetes complications. So our discussion today will be focusing on preventing diabetes among the high-risk populations. So going with the first objective, defining diabetes mellitus and substance use disorder. Diabetes mellitus is broadly described as a chronic metabolic systemic disease, and it is associated with cascades of complications that are mainly associated with abnormalities in the structure and function of blood vessels and nerves. While substance use disorder, on the other hand, is a chronic complex brain disease, and it is characterized by continued engagement on any kind of substance, be it smoking, thank you. Yeah, be it smoking, heroin, cannabis use, opioid use, despite adverse effects. There are three main kinds of diabetes. The first one is gestational diabetes. Can you go back to the previous slides, please? The previous one. Yes, yeah, that one. Thank you. So the first types of diabetes that are very common that we're going to discuss about is gestational diabetes. It's pregnancy induced. Then the second type of diabetes, so that we know the different types, is type 1 diabetes, formerly known as juvenile diabetes. It's insulin dependent. And then the last one of diabetes that we'll be focusing on today, because it's the preventable one, is type 2 diabetes. And type 2 diabetes is the most common of all types of diabetes. It occurs in 90 to 95 cases of all the diagnosed diabetes mellitus. And I also want us to realize that there's a bidirectional relationship between type 2 diabetes and substance use disorder. Because type 2 diabetes is preventable, we'll be focusing more on this type of diabetes, and for the fact that it's the most common of all the of all the diabetes types that are commonly diagnosed. I also want us to take a special look at this picture. We have type 2 diabetes here, we have substance use disorder here. Type 2 diabetes is, the complication is cardiovascular disease, and the complications for substance use disorder is also cardiovascular disease. Both of them also share the same complication of stroke. So type 2 diabetes has complication is stroke, and substance use disorder is stroke. And one thing that I also want to bring up to you during this presentation is that type 2 diabetes is a complication of substance use disorder. As you can see on this slide right here, both of them are included in the global burden of diseases. And the cardiovascular disease is #1 cause of global death, while disability, #2 cause of disability in the globe. The stroke that we discussed about here is #2 cause of death in the globe, and #3 cause of disability across the globe. the diabetes by itself, independently, is number 9 cause of death in the globe and number 8 cause of disability in the globe. So this should make us start to think that we have this global burden of disease, and SUD can result in type 2 diabetes. Type 2 diabetes patients, a lot of them also use substance, they have diagnosis of substance use disorder. So it is very, very important for us to understand the concept that goes on, the relationship that goes on between the two diseases. Next slide, please. Okay. As you can see on this slide right here, the prevalence of individuals that use tobacco that have diabetes complication, which is renal disease, is 12.5. Prevalence of patients with opioid use that have diabetes renal disease is 9.9. As you can see, cocaine is 12.4. It's even higher among those also that use alcohol. Overall cause mortality is 12.9 in tobacco use and 17 in alcohol use. And these are all complications of diabetes that are associated with substance use disorder. Next slide, please. I want us to take a particular look at this slide. The complications, the other complications of diabetes, we're going to start calling it type 2 diabetes because our focus is on the preventable types of diabetes. We have nephropathy, which is the kidney failure. We have retinopathy, which is blindness. For the sake of those who are not clinicians that are among us today, so I'm going to make it simple. We have neuropathy, which is nerve damage. The emerging types of complications associated with diabetes now that we're seeing more and more frequently are cancer, infections, functional disability, cognitive disability, and the most important thing that we need to focus on right now is prenatal exposures. I also want us to think about the cost and the burden. As we're thinking about the burden, we're thinking about the cost associated with it. The global rate of diabetics with kidney failure, which is the same thing as neuropathy, has increased from 42% in 2005 to 52% in 2019. In Nigeria, as an exemplar, it is 32% in 2019. It makes us wonder why we're not doing something about it. In 2019 alone, diabetes-related kidney failure associated resulting in death was about 2 million people. So that is a burden to the society, it's a burden to a lot of people. So now let us continue to think about, next slide, please. Next slide. Okay. So I just want us to, based on what we've learned from the previous slide, I want us to kind of reflect and think about it. Why have clinicians remaining sluggish to preventing, to putting the priority of preventing type 2 diabetes? Why are they sluggish about it? Knowing the fact that these are high-risk populations, especially in the substance using populations. Despite the fact that we have strong evidence to support the efficacy of type 2 diabetes since 1998, and we already have known facts of the relationship between substance use disorder and metabolic syndrome and type 2 diabetes. We've had series series of studies that have showed us the efficacy of diabetes prevention. The outcomes are amazing. We had the Finnish diabetes study. We've had the US-based diabetes prevention study that conducted a study on 3,234 participants. And the study is still ongoing, showing remarkable results. We have the SUD and IntNSA study. We also have the Dan study that conducted among 577 participants. We've had several studies done in multiple low-income countries, like South Africa, India, Malaysia, showing numerous outcomes that type 2 diabetes with lifestyle changes can improve health outcomes. Despite all the studies, clinicians are still not doing anything about type 2 diabetes complications in substance using populations. About 10 years outcome from the US study, diabetes prevention study, showed that there's there's a reduction in new onset of diabetes among the participants, among these 3,234 participants. And that type 2 diabetes can also, once we prevent it, can reduce cardiovascular risk factors. So the burden of substance use and type 2 diabetes, as we can see, is enormous. Can you go to the next slide, please? With the rising prevalence of both diseases, the impact is going to affect a lot of people, because the impact does not only affect the person dealing with it, the impact of these chronic diseases will affect the family members, the community, the society at a local level, regional level, and international level. It affects us all. Bringing poorer health to individuals and aggravating financial costs to the societies. No matter where we are in the world, diabetes-related dialysis, kidney failure, is very costly. The picture I have in the center here is the cost of the hemodialysis in Nigeria per person per year. When average income is low, let's say, for instance, a nurse who has a very high, in a high position, their income, their monthly income is about 300,000 naira to 400,000 naira. If this person have issues with type 2 diabetes, and they result in hemodialysis or the need for hemodialysis, the cost is more than the monthly allowance. So why are we not doing something about it? Next slide, please. Next slide. No, previous slide, please. Previous slide. Okay, thank you. So objective 2, it is important for us to understand the risk associated with development of type 2 diabetes. The risk factors for type 2 diabetes are very complex. They are multigenic and they are heterogeneous, because it could be biological, psychological, sociocultural, and environmental. But one thing that we have to put into perspective is that the mechanism of developing or progression of SUD, substance use disorder, to type 2 diabetes has a primary mechanism in the formation, and the primary mechanism is oxidative stress, is the cellular pathway. So for us to prevent this, we have to encourage our clients to partake or to be participant or to undergo or refer them to diabetes prevention programs. Next slide, please. And the reason why this is important, Objective 3 describes the epidemiological trend of type 2 diabetes or diabetes in general and substance use disorder. The outcome of the World Drug Report, the 2023 World Drug Report, indicated that 23% of increase since last decade in drug use. Next slide, please. And another thing that I want to show us with this slide is that there's increase in the global market of the drug. Apart from the fact that people are using it, we wonder why people are using the drugs and why we should take, we should be more proactive than reactive. There's increase in the use of cannabis. There's increase in the use of opioids. There's an increase in the use of so many other drugs across the globe. Depending, no matter which continent we are, it's all, we have increases everywhere. Next slide, please. And you can see in the next slide that cannabis remains the most drug used globally, and followed by opioids. And as you can see also on this slide right here, this slide depicts that all these drugs is not just only for men. Women are using them too. And the rate of cannabis use and opioids use among women and men is not much different. Next slide, please. And both of them, especially the opioids, we've had overdose of opioids. In this slide, I just want us to see the trend in diabetes across the globe. Diabetes is everywhere. In a study, a recent study that was done the study from the Global Burden of Diseases, 52% of global diabetes was attributed to body mass, increases in body mass index, which is overweight and height. But what can we do to prevent this? Because from what we know right now, we know substance use disorder can result in diabetes. And diabetes also can result in, both of them can combine together. The impact will be too high on an individual or the family members or the community or the society. In the next slide, you will see there's a projected increase of diabetes by 129% for the African nations. Can you go to the next slide, please? See, the African nations, right now, we have 24 million individuals with diabetes. A projection of 129% by 2045, it's bothersome. Next slide, please. Another slide, this slide is from the UNODC. This is particularly for Nigeria. There's increased use in cannabis, and we also have increase of use of other substances. A recent study, I think it was a 2021 study by UNODC, in Nigeria as a country has 14.4% higher rate of prevalence in substance use, drug use. And this rate was much higher than the global average. So my question is, why right now in Nigeria, based on those facts, we do not have evidence that we've had diabetes, translation of diabetes prevention in practices in Nigeria? Knowing the fact that type 2 diabetes can worsen in patients with substance use disorder, and there's likelihood that there will be increase in metabolic problems with these patients? Why are we not doing anything about it? I've shared in the previous slide of the complications, renal failure, the cost associated with it. My question to us is, why are we still sluggish? So, knowing what we know right now, the question I want to ask everyone, especially from the clinicians, my clinicians from Nigeria, what can we do to influence the change in our society? Reflecting on the knowledge gained from my nursing program, I believe that clinicians must be proactive than being reactive. Clinicians must anticipate needs and promote client-centered care. Therefore, individuals with substance use disorder should be considered at high risk for type 2 diabetes mellitus. And education and preventive strategies should be part of the substance use treatment. Preventing substance use disorder and complications were my focus when I started my journey, trying to, when I started the journey of implementing or trying to implement diabetes prevention in Nigeria. I focused on the need to reduce the low value care. I started out the early adopter. Can you go to the next slide, please? What this slide is telling us, we've had series of translations, of DPP translations across the globe. We've had one in India, we've had many in India, we've had in Malaysia, we've had in South Africa, but yet there's no evidence that diabetes prevention program has ever been implemented in Nigeria. We've also had several studies that diabetes prevention program was effective in severely mental patients with receiving treatment for severely mental illness. But yet, we have a gap, a huge gap, with patients undergoing addiction treatment. Next slide, please. So, during the process of trying to influence this change in Nigeria, I sorted out who, where, and how. My who question was, who can I work with? The where question was, where can I start? And then the how question was, how can I get funding for this initiative? To answer these questions, my mentors, collaborators, and two other people like-minded that are willing to, interested in improving the health outcomes of the patients that they care about, or their patients, we all came together and started working and planning. It took us from 2018 to 2022 to build up the collaborating team to support this initiative through my mentors and my colleagues in INTNSA Nigeria, and I think some of them are here today. Many of my encounters were enthusiastic to help and directed me to resources, several resources that I could not even imagine. Among them, can you go to the next slide, please? So these are my early adopters. We're from different areas, both at the local level and global level. So our initiative was actually local to global and global to local collaborating efforts. Next slide, please. And through these encounters of individuals and organizations and entities mentioned above in the previous slide, we assessed the level of needs of various organizations that we could possibly implement or translate this diabetes prevention research study to practice at. We evaluated the risk factors. We also evaluated the protective factors that could either hinder or be a barrier to the implementation. Then we identify the priority populations. Identifying this, we also anticipated the barriers that we will encounter And we thought of the facilitators to leverage those barriers alongside. Our aim in Nigeria is to primarily reduce type 2 diabetes in individuals undergoing substance use maintenance treatment. And the goals were to promote quality health outcomes, and then also to increase the awareness of type 2 diabetes, especially like we're doing it today, increasing the awareness on diabetes on the World Diabetes Day. Then referring patients to the diabetes prevention program. Next slide, please. So the first translation of evidence-based diabetes prevention program was in the addiction unit in the North Central Nigeria. We used the framework called Replicating Effective Model. It's a CDC, the US CDC model. We studied the precondition features that could possibly impact our work. We had pre-implementation plan, and then before we dove into the implementation and the maintenance phase, which we are in currently right now. The study or the initiative was systematically planned, and it is very innovative because we spent very minimal amount of resources, about $7,500, to initiate to implement the program for 1 year. We had our initiative also was to translate the data into priorities of actions, which we did very well. Then the other thing we did with this project was we had a client-centered and age-appropriate intervention. It was a nurse-led initiative. It was evaluated constantly, so we had continuous process evaluation throughout. Next slide, please. The collaborators are interprofessional and intercontinental. We have the nurses, we have statisticians among us, and we also have some medical doctors among us. We have counselors. Most importantly, we had the end users among us. We had the peer facilitators, peer educators. There were patients from this addiction unit. We trained them to be peer educators. They were very, very excited to influence a change among their fellow colleagues. So the end users are peer educators and the patients themselves. And the center is a federally funded data center in Nigeria. Next slide, please. So let's talk more about diabetes prevention, how we went about the program. So objective 4 is actually the application involved in the DPP itself. So the first thing we did was unit campaign. We gave out flyers. We did a lot of talking at the unit. We had the nurses going around introducing with banners, informing patients about the risk of diabetes or type 2 diabetes among substance using population. Then we provided, during the campaign, we provided validated like a tool. It's a diabetes risk assessment tool that has been validated in Nigeria. It's called the Finnish Diabetes Assessment Tool. For those that scored less than 15 on that tool during the assessment, during the screening process, we inform them that they need to follow up with their primary physician for follow-up on blood work, and then for them to be monitored, to monitor themselves every year. For the individuals that had 15, that scored 15 on this validated risk assessment tool, we refer them to the diabetes prevention program. Unfortunately, for this particular initiative, we were unable to assess the serum glucose levels to correlate that with the risk assessment. But all the patients that we had informed us that they were never diagnosed with type 2 diabetes or any form of diabetes in the past. We did not have anyone that was pregnant among the females. We also, so once we after the risk assessment, next slide, please, we refer them to the unit-based diabetes prevention program. Altogether, using the screening, the Finnish diabetes tool assessment, we screened a total of 80 patients. From this center, we had altogether active patients were 242 that were active, but not all of them come to the center every week. Some may not follow up all the time because of financial reasons. We also retained, after the screening, we retained 50 individuals, 50 clients, which are the patients already in the maintenance phase of their addiction treatment program. The remaining 30 that did not join, they had maybe different reasons for not joining, perhaps due to their work schedules, and many due to the vicinity of the hospital or the center, the addiction center, from the town. It's really long, the distance is far. And then in our first session, which is, we call it section zeros, we have 2 section zeros. And for this session zero, during the session zeros, we had the peer educators who were just made acquainted to their peers that they will be working with, so that we start to build a relationship and we start to build trust. So 35 individuals, 35 clients were in the session zeros. Altogether, after the session zeros, before we started like section 1, we had 7 attritions. Altogether, at the conclusion of the project, we have 28 that began the section 1 with us and 28 completed, except for one individual who during the Ramadan season was, I believe, went to Abuja, another state, to celebrate Ramadan with the family members. But he was really enthusiastic about continuing to join in the program, and he completed the program. But only one time, I believe, one person did not show up during the group sessions. So next slide, please. So the characteristics of the patients that we had patients between the age of 22 and 59. We had the weight. The mean weight was 73.2 kilograms, and the mean height was 171 centimeter. The mean BMI was 25. So the mean BMI, as you can see, really it's in the above the normal range. For the Finnish diabetes tool that I discussed earlier, the risk assessment score for the participants in the diabetes prevention program at this center was between 15 and 21, with a mean of 16.8, a standard deviation of 1.4. Majority of the participants were males, and we only had 5 females among them. We had, as you can see also on this slide, majority of these patients already had graduate degree programs. But unfortunately, some of them, even though we did not capture it early, some of them indicated to us that they were unemployed. So next slide, please. 9 of them were married, 16 of them were never married, and 3 were divorced. Of the patients populations that we encountered during the translation of diabetes prevention program at this addiction center, 12 of them, of the 28 patients, 12 of them were currently using tobacco products. 27 of them were still using alcohol, and 27 were still using cannabis. But to my surprise, we had assessment of current use of heroin, but none of the patients indicated that they were still using heroin. So the most substance of use were tobacco, alcohol, and cannabis among this population. Next slide, please. So the intervention, the diabetes prevention interventions were delivered from June of 2022 to June of 2023. So we just recently completed the translation of diabetes, the first translation of diabetes prevention at this center. We have 26 sessions of DPP that with a duration of 1 year duration. We supported ongoing process with the peer facilitators. Support were provided. The lead nurse, every single time before they meet, the lead nurse will provide guidance and mentoring to the peer educators. We conducted process evaluation throughout. And then the first 12 weeks of the implementation, we had weekly virtual meetings. And the purpose of that was for us to be on the same page and for us to conduct the implementation by the protocol that was set up by the ethical, by the ethics of the two institutions, the US institutions and the Nigerian institutions. We were continuously providing feedback. The end users and everybody involved were continuously providing feedback and feed forward. And it was a continuous improvement throughout the process, because what we anticipated sometimes may not necessarily work, but we continually throughout the process we stood by the protocol that were provided during the ethical clearance. Next slide, please. So the first 6 months of the implementation, we call it preliminary report. The baseline, from baseline to section 20. So what happens, let me explain what the sessions, how it looks like. The first 12 weeks were weekly sessions. The second 12 weeks, actually the second 3 months were bi-weekly sessions. So in the first 6 months, we already have outstanding outcomes. We had statistically significant decreases in weight, in the BMI. We had adherence to the food portion control based on the self-reported reports that we received from the participants. But unfortunately, the only variable that were not significant were the dairy product consumption, and then the smoking and cannabis use among this population. Next slide, please. In the last 6 months, which is session 21 to session 26, we had also the same outcomes that we had in the preliminary report. We had decreases in weight, we had decreases in BMI, and they were very significant. You can see p-value was 0.01. We had significant outcomes also for physical activity, replacement of water, replacement of sugar-sweetened beverages with water. We encouraged the participants to consume more fruits and vegetables. And then we also assessed the consumption of intake of grains, proteins, and dairy products, again, per the myplate.gov, the US myplate.gov, which has, in my plate, I think it's the picture is in the previous slide. Half of the plate has to be fruit and vegetables. A quarter of the plate is protein, and another quarter is carbohydrate. Then on the side, we have the dairy product. And similarly, similar to the preliminary results, the cutback in cigarette use was not significant. But the cutback in alcohol intake, alcohol consumption, was significant. And the same thing for cannabis wasn't significant. And we were wondering why this was so, because you know the act that the substances were that were the participant identified using at baseline were the three of them. What made the alcohol intake reduced? So we were not sure whether, because we asked them to replace sugar sweetened beverages with water, perhaps that was the reason why the alcohol consumption was lower. We don't know. Next slide, please. So based on what we have so far, the outcome we are currently disseminating, like I'm doing today about this study, the findings from these translations, the findings, the outcomes were significant to some extent, except for the three variables that were not significant, which was the dairy products, the intake of the use of cannabis, and smoking. Continuously, we were going through, we engaged in ongoing evaluation. And the ongoing evaluation was to strengthen the nursing capacity. Our goal is to sustain this DPP project. And then we had a lot of barriers and facilitators along with this implementation. Next slide, please. The limitations were recall bias. And the reason why we put that first was that the outcomes that we indicated in the chart in the previous slides were reported, because we give them this outcome forms that they have to complete prior to coming to the next, prior to the next session of the DPP. So these reports were provided by the clients themselves. Other limitations that we encountered were socio-political and economical challenges. We had a lot of brain drain. We had one of the nurses that was supposed to support this. She traveled to Saudi Arabia. We also had one of the facilitators traveled to England. And then we had interprofessional rivalries. Next slide, please. So to end this, I want to inform us that nurses are healthcare facilitators. Nurses are influencing contributors in the healthcare system. They are the most prevalent of the healthcare workers. Nurses can influence health promotion and prevention of illness, and they are catalysts to health equity improvement. So what this means is that nurses can practice to the extent of their licensing, if permitted to do so. And prevention, once we have when nurses have autonomy to practice, they can prevent chronic diseases. They can prevent preventable chronic diseases like type 2 diabetes. And that if they are able to do so, it will be beneficial to their patients. And that's one of the code of ethics in nursing. Autonomy, beneficence, justice, and non-maleficence. So nurses can help to improve the decades-long neglect in healthcare services if they are given the autonomy to do so. Next slide, please. Our short-term goals, we want to empower the nurses so that we can strengthen their roles in prevention. We want to also develop new skills in the nurses to be able to influence positive health-related outcomes, promoting healthy longevity. We want to improve nursing-client relationship. We want the peer educators to remain enthusiastic about the work. They are very, very enthusiastic. They come and there was never any day that the peer educators did not show up. We want to employ the peer educators because majority of them, based on the slide that I showed you in the previous slide, they have graduate degree, but some of them do not have jobs. They're not employed. Our long-term anticipated benefit is translation of DPP will reduce expenditures on medical care. It will reduce marginalization of patients with addiction use. It will increase employment in this population of patients with degree, graduate degree holder, but no jobs, no employment. It will reduce the prevalence of homelessness among this population. And lastly, it will reduce stigmatization, because my view, coming in as a nurse, working with addiction patients, is different from what it was before when I learned about mechanism of addictions. Thank you so much. And these are the references. In the next slide, my next slide is a special acknowledgement of these individuals: Charlotte Season, Joanna Travis Roberts, because they conducted, we've been working on this presentation since February. Kevin Mulvey, Dr. Clancy, my mentor, Catherine Fonelli, my other mentors, Dana Murphy Parker, Sharon Border, my colleague, my collaborator. We did this together. I will not even do anything without acknowledging her, Elizabeth Ogunbi. She's a tremendous, phenomenal nurse. And then my other collaborator, Lin Chen. So thank you. And I think it's the end of my slides. I can welcome any question. Thank you all for attending. Thank you.
Thank you, Remy, for an excellent presentation on identifying the nexus between diabetes type 2 and substance use. We have about 5 questions, and folks in the meeting, we're going to be going over our 10 o'clock time frame just to cover some of these questions. So Remy, what I'm going to do is read all the questions first and then allow you time to respond to the questions. So you had mentioned early on that diabetes mellitus prevention programs exist, but can you be a little bit more specific in terms of the types of activities or programmatic activities that exist for substance use folks in low and middle income countries? You mentioned Nigeria, and your study clearly points that out. So one question really is,
Okay.
What types of programs exist, and can they be available in low and middle income countries within perhaps a treatment program for SUD or within a diabetes mellitus prevention program for SUD? The second question is how to prevent gestational diabetes mellitus. Again, how to prevent gestational diabetes mellitus. The third question is, what is the prevalence of individuals developing diabetes who were not previously affected?
I don't have the questions. Okay.
Due to the heavy use of substances in Nigeria. They're on their way. The next question is, how do we involve religious institutions in treatment of persons with diabetes? Because most of them believe in it is a spiritual attack. An interesting study brought about with relatively little financial help. The sample's small, but it's really a comment for your study. Sample small, but we can imagine the results if more people are involved. Would this be a next step of your study in Nigeria? And then another comment, excellent work, Remy. Curious to know if future studies will focus on alcohol as opposed to polysubstance use and what the benefits may be. So those are the basic 5 questions and comments that we've received. So Remy, if you could respond, that'd be great.
What is the prevalence of individuals developing diabetes who are not previously affected due to heavy use of substances in Nigeria? We do not have that study. So my encouragement is that we need a robust study that could to assess or evaluate the epidemiological trends of diabetes or type 2 diabetes among patients with substance use disorders in Nigeria. We do not even have it in the world neither. So apart from the fact that we want to encourage like a robust epidemiological study, we want to encourage that also for across the globe. So the other question that I have here is how do we involve the religious institutions in the treatment of the person with diabetes, because most of them believe in a spiritual attack? That's a good question. You know, even though we've had studies of faith-based implementation of type 2 diabetes prevention, religious institutions also, if the patients are trusting the leaders in this at this site, if they are trusting their fellow believers at this site, religious institutions also could develop or could have a nurse-led implementation of diabetes prevention program at various sites to improve the health outcomes of their congregants. So the next question that I have, an interesting study brought about with this person says an interesting study brought about relatively little financial help. The sample is small, but we can imagine the result if more people were involved. Will this be the next step for your study in Nigeria? Absolutely. We want to extend and increase the capacity and scale this project because we have a lot of high need population. But our goal was to do the nationwide implementation will be too costly and will be overwhelming. So getting the result from the little standalone site was very beneficial for us. And we can now think about how we can scale and translate diabetes prevention program at other various sites in high need, high risk populations. Then number 5, excellent work. Curious to know if future studies will focus on alcohol as opposed to polysubstance use and what the benefit may be. We really don't know. Like I said in the previous slide, we don't know why the reason why alcohol consumption, we had significant reductions in alcohol consumption compared to cannabis use and smoking. Perhaps because we encourage them to drink water and replace sugar sweetened beverages with water. We really don't know. Then the other questions is role of nurses for CKD and type 2 diabetes patients. It's a lot of things that nurses can do to prevent this. And in the slides that I shared with you, dialysis is very, very, very costly. Why do we want to wait until the patients have dialysis or they have kidney failure before we intervene as clinicians? We can integrate the type 2 diabetes, knowing what we know right now about the relationship between substance use disorder and type 2 diabetes is bidirectional. We can start to integrate type 2 diabetes in all the treatment care that we have, and encouraging patients physical and mental health care, integrating physical care into the mental health care too. Yeah, these are all the questions I have so far. Are there any other questions?
So thank you, Dr. Adejumo. I believe we are out of time at this moment, but we thank you again for your excellent presentation and your research results.
Okay.
We look forward to hearing more.
By now, I mean, the goal is that we can influence a change in our society in the care of the patient we provide services to, and that we hope that we can influence a change in healthy longevity, because our older populations are dying of chronic preventable diseases. We can prevent this. Thank you.
So again, thank you all for attending this important session related to diabetes mellitus and substance use disorders. Again, just a reminder, the recording of the webinar will be available on the ISSUP website, the YouTube channel, and a certificate will be sent to you after the webinar. We hope to see you again in future webinars by both INSA, ICUDDR, ISSUP, and we wish you a great day or week or evening, depending upon where you are. Have a good night, have a good day, have a good afternoon. Take care.